Welcome to Banff Nursing. In this video, we will talk about gastroesophageal reflux disease, GERD, also known as acid reflux. We will discuss the risk factors, signs and symptoms, diagnostic tests, and treatment options. Let us dive into the pathophysiology of GERD. Gastroesophageal reflux disease is a chronic condition marked by the backflow of stomach contents into the esophagus, resulting in inflammation and irritation of the esophagus. This condition occurs due to an incompetent lower esophageal sphincter and causes troublesome symptoms like heartburn, which occurs mostly at night, and mucosal injury to the esophagus. The esophagus has two important sphincters, the upper esophageal sphincter and the lower esophageal sphincter. The upper esophageal sphincter prevents the reflux of air into the esophagus during respiration, while the lower esophageal sphincter prevents the reflux of stomach contents into the esophagus. Please note that gastric acid normally stays in the stomach and is prevented from entering the esophagus by the lower esophageal sphincter. Excessive reflux of acid into the esophagus usually occurs after a meal due to an incompetent lower esophageal sphincter or conditions that increase intra-abdominal pressure compared to the pressure in the esophagus. Let us change gears and review the risk factors for GERD. Risk factors for GERD: male gender, smoking or tobacco use, coffee drinking, alcohol consumption, delayed emptying of gastric contents, obesity, ascites, pregnancy, eating large meals, loss of esophageal motility, gastric infection with Helicobacter pylori, weakened lower esophageal sphincter. Common signs and symptoms of GERD: pyrosis, which is episodes of heartburn associated with burning pain in the epigastric area, frequently occurring at night. Dyspepsia, which is indigestion of food. Hoarseness or changes in voice due to irritation of the vocal cords. Chronic cough due to irritation of the trachea in the lungs. Dysphagia or odynophagia, regurgitation. Diagnostic tests for GERD. Gastroesophageal reflux disease may be diagnosed based on a careful evaluation of patient history to rule out other possible causes. Ambulatory pH monitoring may be done for 24 hours to evaluate damage to the esophagus. A barium swallow or upper endoscopy, EGD, may be done to examine the esophagus, which may show esophageal changes like irritation from chronic reflux, narrowing, and ulcers. Esophageal manometry or motility test may also be done to measure the lower esophageal sphincter tone. The aggravating factors that may reduce the lower esophageal sphincter tone. GERD is associated with coffee drinking, cigarette smoking, consumption of alcohol, fatty foods, consumption of mint, consumption of chocolate, large meals, and gastric infection with Helicobacter pylori. Treatment options: antacids, acid neutralizing agents like calcium carbonate, alginate, aluminum hydroxide, magnesium hydroxide, and simethicone are prescribed to neutralize the acidic contents of the stomach. Histamine 2 receptor antagonists, like famotidine and cimetidine, may be used to decrease gastric acid production. Prokinetic agents, like metoclopramide, Reglan, may be used to accelerate gastric emptying. Please be informed that long-term use of Reglan is associated with tardive dyskinesia. Proton pump inhibitors, PPI, such as pantoprazole, omeprazole, lansoprazole, and dexlansoprazole, are used to reduce acid secretion by the stomach. It is good to note that long-term use of PPI is associated with hip fractures. Reflux inhibitors, like bethanicol, may be used to stimulate parasympathetic activity. Please note that bethanicol should not be given to patients with gastrointestinal obstruction. Surface agents, like sucralfate, may be used to prevent mucosal barrier damage. It is good to note that sucralfate should be taken on an empty stomach, either 1 hour before a meal or 2 hours after a meal. Also, separate it from doses of antacid by 30 minutes. If symptoms are resistant to medications or are caused by hiatal hernia, anti-reflux surgery such as open or laparoscopic Nissen fundoplication may be done to strengthen the lower esophageal sphincter. Complications associated with GERD: Barrett's esophagitis, an irritation of the lining of the esophagus marked by cell changes that can result in chronic reflux or esophageal carcinoma. Dysphagia, difficulty swallowing and vomiting may occur. Esophageal stricture, caused by scarring and narrowing of the esophagus, which may interfere with the passage of food. Esophagitis, chronic inflammation and irritation of the esophagus. Lifestyle modifications and patient education. If obesity is the problem, weight reduction, nutritional, and exercise counseling should be advised. Educate patients to adhere to their medications. Abdominal pressure can be reduced by eating small, frequent meals rather than 3 large meals. Educate patients to wear non-restrictive clothing because tight clothes like girdles or belts may lead to increased intra-abdominal pressure. Sitting up during and after meals should be encouraged. Avoid taking NSAIDs and certain medications such as smooth muscle relaxers and anticholinergic medications because they may decrease gastric emptying. Avoid eating spicy and fatty foods. Patients should be advised to avoid carbonated beverages, beer, and highly acidic foods like orange juice and tomato sauce. Avoid triggering foods like caffeine, fatty foods, fried foods, garlic, chocolates, citrus foods, tobacco, dairy products, and foods containing peppermint. Avoid eating or drinking 2 to 3 hours before lying supine or going to bed. Avoid lying down immediately after eating with a full stomach. Elevate the head of the bed by at least 30 degrees to prevent the backing up of stomach contents into the esophagus. Eat small, frequent meals per day instead of 3 big ones. Thanks so much for watching. If you like this video, please do not forget to subscribe, share, like, and click the bell icon for more educational videos. If you have other topics that you want us to discuss, kindly drop it in the comments section.